Thank you all for coming. Dr. Potash, Dr. Jinx Chang, thank you for discussing our patient's case. I definitely want to highlight that, and I'm going to just quickly move through these CME slides here, which are available, and state that I have no conflicts of interest related to this presentation. With regard to this patient population in particular, that motivation to engage in treatment is dynamic and that it's to some extent developmentally consistent for a young person to sometimes show up and sometimes not show up. And so really there's an adapting to working with young people who have substance use problems and co-occurring mental health problems where you meet them where they're at. And that's a lot of what we do, is be adaptive and flexible. So for my portion of the grand rounds, I'll be talking about intergenerational cycles of addiction and how to disrupt these through focusing on at-risk youth and families. I throw up this slide just to really present what I think is just sort of the sobering context in which a young person is really growing up today. I think it's hard to grow up in contemporary America where really the population of children and adolescents, this generation is really growing up in a confluence of four epidemics, if you will, three related to substance use, and then the COVID pandemic. There's been an opiate overdose epidemic that we're now in our fourth iteration of. We've seen dramatic changes in state and also federal cannabinoid and other drug policy that's really changed the societal landscape in terms of attitudes and perceptions. And we've seen really a explosion of technology focused on the service of advancing administration of psychoactive drugs, and this explosion of vaping and other ways of administering intoxicants that makes it complicated for young people. Gene Bowden is quoted as saying, "History teaches us the mistakes we're going to make." And so one of the things that I posit to us today to sort of chew on and consider is U.S. history repeating itself with regard to our patterns of drug use and our control policies. We can see across the history clear time points where there's been attempts to medicalize in the service of profit different psychoactive drugs and make exaggerated and really broad medical claims about them in the absence of safety and efficacy data. I think we're seeing some of that today. And then there's also been clear aspects of our history where advertising, packaging, and product types have been created and widely promoted that really are clearly designed to target and attract the next generation of users in the service of profits. The late psychiatric historian David Musto really, I think, colored and really developed this field, and is perhaps the only historian who could give Jim Harris a run for his money with regard to historical knowledge of mental health and substance use cycles. David Musto's book, The American Disease, really speaks to these repeating cycles of drug abuse epidemics and drug control policies that vacillate from permissive to restrictive, that keep on repeating itself through America's history. And some of this is on account of really the short span of public memory. that doesn't cause us to take a more logical and rational approach. So pulling back to contemporary America, trends and prevalence of substance use among young people, what we've seen, despite decreases in alcohol and some other drugs, we've seen elevation of vaporized nicotine products and smoked and vaporized cannabis use products, which have remained somewhat stable over time, and with the vaping portion in particular increasing. With regard to young adults, we've seen also a dramatic increase in cannabis use, both past year and regular use, which is now at or near historic highs since this data really started being collected. And we've also seen an increase in hallucinogen use in the population. I want to highlight that cannabis use disorder is the main substance use disorder that young people are diagnosed with and the primary drug that we treat in youth substance-targeted clinics. Overdose rates are also rising in young people. There's been more than a twofold increase in unintentional drug overdose deaths in adolescents in the past 5 years. This is driven predominantly by fentanyl in the illicit drug supply, with some young people with opiate use disorders dying from drug overdose, but also some young people who are just experimenting with street drugs or prescription drugs, taking a drug that they maybe think is a Xanax or a Percocet and it's contaminated with fentanyl and dying from a drug overdose, really highlighting the importance of overdose education and naloxone prescribing in our clinics. Beyond overdose, adolescent substance use and substance use disorders are associated with adverse outcomes across multiple psychosocial domains. I list all these various domains here and just want to highlight that adolescent substance use and substance use disorders are associated with really the top leading causes of morbidity and mortality in this age group, with really death predominantly caused in adolescents and young adults by outcomes that result from impulsive behavior. And this really sort of highlights, I think, the importance of taking a developmental approach here. Our group has contributed to this work. This slide shows results from a study led by Dr. Carol Vidal in our Division of Child Psychiatry, where we examined past 30-day health correlates of past 30-day cannabis use in over 40,000 college students across North America, and found that past 30-day cannabis use was associated with greater rates of depression, suicidal thoughts and behaviors, anxiety, violence, victimization, and eating disorders, even after adjusting for multiple covariates. Stephen Covey is quoted as saying it's start with the end in mind. And so this slide really shows my major take-home points that I want you to really take from this presentation today. I'm going to hit on each one of these and kind of unpack them in a little bit more detail across the arc of this presentation. But these points are addiction is a pediatric and a familial disease. Addiction is a co-occurring disorder. Addiction is preventable and is treatable, and we need to do a better job of doing those. Drug policy matters for public health outcomes, and really with the central thesis being that really translational research and investments in prevention, early intervention, public health and education are really keys to progress in this space. So my first take-home point, addictive disorders really can best be conceptualized as neurodevelopmental conditions with pediatric origins that really have a pediatric onset for most people who start using. More than 90% of adults who are diagnosed with a substance use disorder, those adults that are presenting to the clinics of my colleagues that are working in the various adult settings. If you ask those people, when did you start using? More than 90% of them will say, I started using during adolescence, and I started using regularly during adolescence. This slide, which shows data from the NESARC study, highlights this signal showing that first onset substance use disorder for the three main drugs of abuse that people use in our society, tobacco, cannabis, and alcohol, all peak during adolescence or young adulthood and then decline thereafter throughout the lifespan. And so really targeting beforehand or early during this process is part of the key to really flattening that curve. A few additional epidemiological data points just to chew on here. Despite some improvements related to prevention efforts that have been done across the country, most U.S. adolescents will still experiment with alcohol or drugs before the age of 18, and a significant minority of those young people who experiment with and try alcohol or drugs more than a handful of times will develop a substance use disorder. Data from the National Survey on Drug Use and Health shows that about 8.5% of 12 to 17-year-olds meet criteria for a substance use disorder, and about 25.6% of 18 to 25-year-olds. This statistic is, I think, one of the most sobering, and it's getting worse. It's fewer than 1 in 10 of these youth who meet criteria for a substance use disorder and who would benefit from some sort of substance-targeted intervention ever receive formal substance use treatment. So this treatment gap is a big issue, and it's actually getting bigger. So the number is really shifted from about 10% to about 7% in the past 15 years. Speaking of, I think, some of our struggles to really target and address this population in this era where societal perceptions about substance use are shifting. Substance use during adolescence progresses through different stages and levels of use, and it's helpful to think of these as we're targeting young people. Initiation, experimentation, recreational use, risky and problematic use, disordered use, and then cycles of abstinence and recovery. Adolescence represents a developmentally sensitive time window for a number of reasons, making them both more sensitive to drug exposure and more vulnerable to developing a substance use problem compared to adults. The figure on the right-hand side of this slide shows developmental differences in the brain systems that are involved in cognitive control, reward and emotion processing, and how they differ from childhood to adolescence to adulthood. And what we see is that during adolescence, it really represents a period of time where the prefrontal cortex, which matures at a later stage in time than subcortical structures like the striatum and the amygdala and regions involved in motivation, reward, and emotion reactivity, is immature compared to those reward and emotion processing regions, and is really at this imbalanced stage that maps onto a time window where young people during adolescence are developmentally more sensation-seeking, more emotionally reactive, more socially reactive, and are more likely to engage in risk-taking behaviors, including drug and alcohol use. At the same time, the figure on the left-hand side shows cannabinoid 1 receptor expression across the brain, and as you can see, I use the same directional brain figure to highlight that cannabinoids are expressed highly in these brain regions that are undergoing a staggered maturation, making young people who use alcohol, cannabis, or other drugs more vulnerable to having their brain development disrupted with use during this time window. Work from my group and from a number of other groups from around the country have found evidence that adolescent cannabis and also other drug use is associated with short and long-term effects on human brain function and structure. Without diving into major detail here and focusing specifically on cannabis for the standpoint of this slide, the literature really shows mixed evidence for structural alterations, but does show evidence for potential white matter tract disruption and alterations in brain function as measured using electrophysiology or EEG and blood oxygen level signal as measured using functional MRI, with adolescent cannabis and other drug users showing a typical pattern of altered brain blood flow, altered brainwave activity, and changes in these both at rest and also in response to different neurocognitive tasks that they perform when we scan them while measuring their brain activity. Across studies, these effects seem to be larger and more consistent with earlier age of onset and more chronic and persistent use patterns, suggesting a potential dose response there. Much of the work that I do really is focused on, can we use the information from these studies that show alterations in brain function and structure and use them to really inform improvements in how we treat young people with substance use disorders. And this slide shows results from two different coordinate-based meta-analyses of functional neuroimaging studies where we aggregated data across studies where they applied neuroimaging with treatment in treatment populations and looked at associations between treatment, between brain function and treatment response. And what we found is that a number of brain regions, particularly in attentional default mode and salience networks, are associated with treatment responses and may represent brain-based targets for us to consider either stimulation-based treatment or to inform biomarker development in this space. The second main point of my presentation, addiction is a familial disease. I think it's really important to highlight this, and the case that was presented, I think, emphasizes this as well. The family ecosystem plays a central role in the intergenerational transmission and also in recovery from addiction, with the family system being both influenced by and influencing substance use in both the parent and also the young person. Parent and caregiver functioning and behaviors can represent risk or protective factors for the development of substance use in children. And in the context of this, really promoting the health of the parent is health promotion in the child and the family, and we should really be thoughtful about this. This slide shows just some of the sobering statistics on familial substance use in our society. 1 in 4 children in the US are exposed to alcohol use disorders in the family system. Data from now about 8 years ago shows that from national surveys show that 8.7 million children under the age of 18 live in a household with at least one parent with a past year substance use disorder. A study published in JAMA Psychiatry this past year highlights where the opioid epidemic intersects with this, showing that more than 321,000 children lost a parent to a drug overdose death in the past decade, with racial and ethnic health disparities being identified in this particular finding. The number really defines one of today's major public health problems and represents something that we really should be thoughtful about in our clinics, not just those programs that are targeting individuals with substance use disorders. The data shows clearly that children exposed to parental or familial substance use have worse psychosocial, functional health, and academic and vocational outcomes. There's also a message of hope that I want to emphasize here. There's also data pioneered from the past really half a century from groups like the National Organization or the National Association for the Children of Alcoholics, which is now the National Association for the Children of Addiction, and from groups like Jerry Moe, who is the director of the Hazleton and Betty Ford Clinics children's program that really has taught us how to work with young people whose parents have substance use disorders and who experience trauma or adversity related to their parents' substance use disorders. This picture shows Jerry Moe in a famous episode on Sesame Street teaching children about addiction. And I want to highlight the 7 C's, which Jerry Moe came up with. That's a way of teaching young children about their parents' addiction. You didn't cause the problem, you can't control it, you can't cure it, but you can help care for yourself, you can communicate your feelings, you can make healthy choices, and you can celebrate yourself. At Johns Hopkins, really through this larger interconnected network between child psychiatry and adolescent medicine, we've developed a family-centered model that really focuses on working with children, adolescents, and families suffering from addiction with the Co-Occurring Disorders Clinic based on the Johns Hopkins Bayview campus in the Community Psychiatry Program, and the Care Clinic based here on the Broadway campus in pediatrics. And it's really, and our program really is family-centered and focused on taking care of the whole person and the whole family within their context, and targeted at really addressing, really providing a continuum of services from prevention to early intervention and treatment. Addiction truly is a co-occurring disorder, and this is a third point I want to make that I want you to take home from this presentation. Co-occurring psychiatric disorders are really the rule rather than the exception in young people who use alcohol or drugs or who meet criteria for a substance use disorder. The data really shows that about 75 to 85% of young people who have a substance use disorder meet criteria for one or more co-occurring psychiatric disorders, with the average young person meeting criteria for about 2.5 psychiatric disorders. This slide shows the different psychiatric disorders that commonly co-occur in youth who present to clinical settings for treatment of substance use disorder in particular. There are complex bidirectional relationships between substance use and psychiatric disorders that really should inform how we think about co-occurring disorders. Psychiatric disorders or subclinical psychiatric symptoms may predate, run concurrently with, or evolve as a consequence of chronic alcohol or drug use, with the symptoms really becoming linked over time. There are significant individual differences that exist, and the relationships are complicated and really vary in part as a function of psychiatric symptom category, drug type, potency, administration method, use pattern, the time frame, whether we're measuring the association between, for example, depression and cannabis use during an acute intoxication phase or during a short-term or a long-term window, and whether someone is intoxicated or in a state of withdrawal. Many youth and adults report that I'm self-medicating with cannabis or with other drugs I'm using to relax and cope with stress. And this drugging to cope with negative affect is really a major signal in individuals with co-occurring disorders that we need to pay attention to and target as a part of how we care for them. I want to highlight that the longitudinal studies show the opposite pattern, though, of that acute self-report by young people and older adults. Most longitudinal studies generally show a positive long-term association whereby greater substance use tends to be associated with poorer courses of depression and anxiety and worse mood outcomes over time, and mental outcomes in general. And then the co-use of different drugs also is impactful. About half of young people who report daily cannabis use, for example, also smoke cigarettes or vape nicotine, and using these together in combination also have complex effects on both psychiatric symptoms, behaviors, and brain functioning. And so really it takes complex longitudinal analyses to parse these associations out. And I just show this study to highlight some of the work that my group is doing. This study is a post hoc analysis from the Cannabis Youth Treatment Trial, which is the largest clinical trial ever conducted looking at the treatment of cannabis use, where they compared 5 different psychosocial interventions. And we did path analyses examining time-lagged associations between cannabis use and depressive symptoms over time during and after treatment, and found that changes in cannabis use, specifically reductions in cannabis use, tracked concurrently with reductions in depression, both during treatment with then those effects lasting into the post-treatment period for youth receiving treatment for cannabis use. Addiction is a preventable and treatable condition, and there's good evidence-based preventive interventions and also treatments for substance use that do show effectiveness, at least for some young people, but are underutilized, especially for youth and families from racial and ethnic minority populations, unfortunately. So this slide highlighting the Partnership for a Drug-Free America. Drug use is a preventable behavior and drug addiction is a treatable disease. From a prevention standpoint, it's really the main goals and the main way that we think about prevention, and that I'd challenge everyone in this room who maybe thinks, I don't treat substance uses, to conceptualize your work in terms of mental health care as a treatment, as a prevention for substance use in your patients. And the main goals of prevention are really to enhance protective factors and reverse or reduce risk factors. Nikki Alongo from our School of Public Health, I think, stated well the rationale for really this approach, and it's really early intervention with risk factors has a greater impact than later intervention by changing a child's life path and trajectory away from problems and towards positive behaviors. And so always thinking about where the different environmental factors that we know are associated with poorer outcomes, where those fall on this dynamic seesaw of risk versus protective factors, and what can I do to modify the balance here is something I'm always recommending to clinicians. This slide highlights really the state of the evidence for psychosocial interventions for adolescent substance use disorders. At the present, there's strong evidence to support the use of these psychosocial or behavioral interventions as really the primary or first-line treatment for young people. with substance use and addictive disorders, with motivational interviewing approaches, cognitive behavioral approaches, family-based approaches, and contingency management or reinforcement-based approaches, all showing effectiveness, and there's the capacity to integrate or use these in combination to potentially get better outcomes. But taking a step back to really a healthcare system or sort of a public health standpoint, how does a health system do a better job of targeting substance use? And what the American Academy of Pediatrics and SAMHSA both recommend is applying what's called SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. This is really an evidence-based early intervention strategy that applies universal screening in settings where people present who may have risk factors, such as the primary care setting, or mental health clinics that are not specialized for substance use, or even in school settings, and applying universal screening and using that screening to risk stratify young people to different risk levels, and then deliver brief interventions tailored to the specific risk level. This idea of really a continuum of substance use risk trajectories requires a continuum of interventions, and this is something that we can do. And again, I want to highlight this importance of access, and that youth addiction treatment services really differ by race and ethnicity, and this contributes to poorer outcomes for these populations. And we need to figure out a better way of targeting and getting care that is evidence-based to these groups. The last 2 to 3 minutes of my presentation, I'm just going to talk a little bit about my work in drug policy, which really emerged out of observation in my clinic, where I just began to see more and more young people present with a cannabis use disorder or another substance use disorder, and their parent has a medical cannabis card and is giving that young person cannabis, feeling like that's going to help their mental health outcomes. Really, we live in a world where there have been such broad changes to the US drug policy and really the societal landscape. It's really changed the conversations we have to have with our patients, and highlights an area where we need to spend more time actually in education and talking with patients and families in the service of helping them. This slide, which I apologize is busy, shows work from primarily my group, highlighting some of the changes that have occurred with regard to cannabis use patterns during this age of cannabis legalization. We've seen increases in cannabis use, regular use, and disordered use in parents of young people. We've seen increases in availability and accessibility of cannabis products reported by US teens. Many teens who use, get diverted cannabis from dispensaries. We've seen just an explosion of different types of products, sources, methods of administration. Your average teen who uses cannabis is a polycannabis user who uses in multiple different ways. Vaping has become the predominant use of cannabis among young people. And there's been an increase in vaping of delta-9 THC, but then also other cannabinoids such as cannabidiol and hemp-derived THC analogs such as delta-8 and delta-10, as well as an increased use in high THC potency cannabis concentrates. The use of these products is problematic in part because we have growing data showing that potency is associated with worse response in young people. The rates of cannabis use among young adults is increasing, and all the while the perception that cannabis use is harmful to one's mental health and physical health has decreased and is now at an all-time low across every age group in the United States. There's also been an increase in cannabis-related emergency department visits, hospitalizations, and motor vehicle crashes. Our group has contributed a lot of work to this space. This slide shows results from a study led by myself and Leslie Miller from the Child Psychiatry Division, where we surveyed youth receiving mood disorder treatment and their parents and providers, and asked them about cannabis and CBD products. And we found that more than 75% of youth and 65% of the parents perceived both cannabis and CBD products to be safe and effective treatments for mental health, with half of both groups telling us that we should be prescribing this to them. In terms of the direct effects of cannabis policy on youth health outcomes, work from my group has shown that recreational but not medical cannabis laws has been associated with an increase in cannabis use in U.S. adolescents and young adults, and changing state medical and recreational cannabis laws has also been associated with an increase in suicide-related deaths among female youth, 14 to 16-year-olds, regardless of sex, and also Hispanic and Asian youth. These highlight what I think is a really important take-home point, which is that we should be having conversations with our patients, and we should be encouraging parents to have a marijuana talk with their pre-adolescents as a part of thoughtful prevention in this space. And I've included a number of what I think are useful clinical sources. And so I'll just sort of land on this as revisiting these major take-home points. Addiction is a pediatric and familial disease. Addiction is a co-occurring disorder. Addiction is preventable and treatable, and we need to do better. And drug policy matters. And with the central thesis being that translational research that embraces the complexity of studying this and focuses on youth and families is needed, and investments in prevention, early intervention, public health, and education are really keys to progress here. And then, since it's Thanksgiving, I want to definitely give thanks to all of the people who I've worked with in this space. As I've sort of given a big tour of a variety of the different things that of really this field, you can see that it really takes a village to both care for these young people, but also to really do the types of multi-level research needed to understand these associations. Thank you.
Thank you, Dr. Hammond. Let me ask you this. The legalization of marijuana, I suppose in some ways makes it a lot like alcohol. That is a problematic substance that's legal. Does that have an impact on this issue of the degree to which clinically you emphasize complete abstinence as opposed to saying it's okay as long as you keep it in small?
I'm glad you asked that question, because I think it's a really salient one. With regard to alcohol, it's both a good and a bad comparator, because alcohol was legal for much, much longer in our American history than it was illegal. And so going from something that's been predominantly controlled or not used regularly to something that is legal is a different beast with regard to societal changes. When we have conversations with young people and their families about cannabis, the slides I presented showing associations between youth substance use and adverse psychosocial outcomes, what the research really clearly shows here is that youth substance use, even use that does not meet the threshold for being problematic or for being disordered use, thus meeting the criteria for a disorder, is still associated with worse psychosocial outcomes. And longitudinal studies have shown a clear dose-response relationship based upon frequency of use during adolescence and persistence of use during adolescence and greater mental health problems and psychosocial adversity. And so in the context of that, we always take an approach where we encourage and promote abstinence as really the primary pathway forward with young people and their families, and that's what we recommend. At the same time, we also meet young people where they're at and realize that some young people don't want to stop. And so for those young people, we approach, recommending, why don't you cut down? What would that look like? What would a thoughtful harm reduction strategy look like, shifting from really high potency THC products to products that contain CBD? And that might actually be a good harm reduction strategy, but we don't have enough evidence there. And so I'm extrapolating from the few studies that have been conducted. But does cutting down, does non-abstinence reduction, is that associated with better outcomes? And it may be. And so we definitely take that approach on a case-by-case basis. But I think shifting away from a philosophy of that abstinence is the best model is I think creates a slippery slope that's not helpful for young people or their families.
Thank you. We are out of time, but thanks very much for that interesting talk.